3/4 of US health systems are already running AI in some form. Only 16% have a plan to govern it. And in 2025, 1 in 5 healthcare organizations had a breach directly tied to shadow AI. That is not a future risk. That is a current incident log. Healthcare is buying and deploying AI tools faster than it is building the oversight to run them safely. That gap is where privacy leaks, clinical risk, and vendor exposure are already showing up in your systems. In boxing, if you step into the ring with your hands down, throwing wild combinations without setting your guard, you aren't being aggressive. You're just waiting to get caught on the chin. In healthcare technology, that is exactly what we are doing with AI. I'm Chris. 20 years in healthcare, the last decade in cloud and AI. I'm the healthcare architect. In this video, I am going to show you exactly where the governance gap is, why it exists, and the practical structure you need to close it before the next board question becomes a breach notification. A 2026 Eliciting Insight survey of 120 health systems found 75% using at least one AI tool, with half running 3 or more. Only 16% have an enterprise-wide AI governance plan, according to a Censinet and College of Healthcare Information Management Executives Foundation survey. That means AI is already running ahead of the operating model meant to keep it in check. The pressure shows up in 3 places. Shadow AI first. Staff are using public generative AI tools to draft notes, summarize records, and reply to patient messages. The appeal is obvious. These tools save time, but they also slip past information technology review and logging. The data immediately leaves the organization's control. Wolters' Kluwer survey found that only 18% of healthcare professionals were even aware of formal organizational policies governing generative AI use. The problem is not reckless behavior. It is a mismatch between the approved technology stack and what frontline staff need in the moment. Once protected health information enters an unvetted tool, the organization loses visibility over where that data goes, how it is used, or whether it could be exposed. Clinical decision support is the second pressure point. Once AI shifts from drafting content to making recommendations, the risk profile changes. Patient safety moves to center stage. AI-driven risk scoring, diagnostic suggestions, and workflow prioritization are only as safe as the review around them. Errors get missed when clinicians do not have time to evaluate outputs closely. That creates both clinical exposure and compliance exposure at the same time. There is a second problem that nobody talks about enough. Post-deployment reviews are rare. That means model drift can pass unnoticed. A tool can look fine at launch and then slowly drift off course while still being treated as reliable. Vendor AI is the third gap. A significant portion of healthcare AI does not come through internal procurement at all. It arrives bundled inside vendor products. Many agreements were written before AI features became standard. A vendor can roll out expanded AI-enabled functions through a product update, while the healthcare organization has limited visibility into data use, model changes, and downstream dependencies. AI Compliance Insider reported that a vendor's AI charting tool, adopted by 7 health systems on day 1, created upcoding risk without documented human review. The regulatory layer is the first problem. Healthcare AI is governed by overlapping rules, not one coherent framework. FDA, HIPAA, federal healthcare programs, and state laws each cover part of the problem. The gaps sit in the spaces between them. FDA covers certain AI-enabled software and device-related use cases. It does not cover every AI workflow inside a health system. HIPAA protected health information, but it does not govern model behavior, drift, or post-deployment performance. Federal healthcare programs cover payment, coverage, and program integrity. They do not provide an AI safety framework. State laws are moving faster, but they don't line up neatly. By early 2026, state lawmakers had introduced over 250 bills related to artificial intelligence. According to Manatt Health, 33 of those have already been signed into law across 21 states. Texas, California, and Colorado added disclosure and governance requirements effective January through June 2026. That sounds like progress. But disclosure rules do not run day-to-day operations. Voluntary frameworks help, but they do not operationalize governance. The National Institute of Standards and Technology's Artificial Intelligence Risk Management Framework gives organizations a way to think about risk. That is useful. But it does not set risk tolerance, assign approvals, or monitor models over time. It does not name owners or keep watch over tools in use. A Censinet and College of Healthcare Information Management Executives Foundation survey found more than half of US health systems were already deploying AI before formal regulatory guidance was in place. Only 16% had an enterprise-wide AI governance strategy. Many teams were using AI while leadership was still figuring out who was supposed to manage it. Ownership fragmentation is the third and most structural problem. AI oversight is routinely split across legal, compliance, information technology, procurement, and clinical teams. No single person owns the full life cycle. No one team handles intake, approval, monitoring, incident response, and retirement from start to finish. The accountability gap becomes concrete when you ask a simple question. A vendor updates a model. A clinical team starts using a tool in a new way. Output quality slips over time. Who catches it? Who decides whether the issue needs escalation? In many organizations, the answer is fuzzy. And when ownership is fuzzy, blind spots show up fast. Closing these gaps takes three things working together. First, a cross-functional governance committee with clear decision rights. Clinical leadership, information technology, cybersecurity, privacy, compliance, legal, risk management, and procurement all need a seat at the table. But a seat is not enough. Each person needs explicit decision rights before any tool goes live. And every AI tool needs one named owner. That person is accountable for performance, validation, and escalation. For high-risk use cases that affect diagnosis, treatment, or reimbursement, executive-level accountability is also needed. Banking offers a useful comparison. In 2025, the Financial Services Sector Coordinating Council published the Financial Services Sector Artificial Intelligence Risk Management Framework, with 230 control objectives developed alongside more than 100 financial institutions. Healthcare, by contrast, has 16% enterprise governance coverage and no equivalent sector-wide framework. Banking was forced to build structured AI oversight earlier because regulators demanded it. Healthcare is still waiting for that forcing function. But waiting is a mistake. Strong governance is actually the only way to deploy AI faster. Without clear guardrails, your legal and compliance teams will block every single high-value AI pilot out of sheer caution. An operational framework isn't a brake pedal. It is the suspension system that lets you move fast on rough roads. Second, a central AI inventory. This is the visibility foundation. A Censinet cybersecurity benchmarking study found only 30% of healthcare organizations had one in early 2026. Without it, an organization cannot see where risk is already in motion. That inventory should include every AI system in use, including shadow AI discovered through network monitoring. Once that list exists, leaders can sort tools by risk and apply controls that match. For high-risk tools that influence diagnosis, treatment decisions, coding, or reimbursement denials, the controls need to include human review built into the workflow, continuous bias monitoring, and inference-level logging of every output. Lower-risk administrative tools still need security review and vendor monitoring, but the control set can be lighter. Third, continuous monitoring that does not stop at go live. Governance cannot end when a tool launches. Model drift can erode performance gradually. For high-risk AI, monthly performance checks against the launch baseline plus annual risk reassessments are the minimum bar. The Department of Health and Human Services proposed revision to the HIPAA security rule puts AI systems that handle electronic protected health information squarely in scope. Audit logs capturing prompts, outputs, model version, and user identity are not optional. They are a compliance requirement. Vendor AI must be governed as part of the supply chain. Business associate agreements should be audited for AI update rights, liability tied to AI outputs, and limits on retraining. The Kaiser Permanente $556 million settlement with the Department of Justice in January 2026 for submitting unsupported diagnosis codes shows what happens when coding runs without clinical traceability or human review. The organizations that are navigating this well are not necessarily the largest or best resourced. They are the ones treating AI governance as an operational discipline rather than a one-time policy project. And they start with the highest risk use cases first. The practical sequence starts with inventory. In the first 30 days, build a centralized list that covers sanctioned tools, active pilots, vendor AI features, and shadow AI found through audit trails. Days 31 through 60, classify each tool by patient safety impact, billing risk, and operational risk. Assign named ownership and escalation paths. Days 61 through 90, implement controls for high-risk use cases. No unmanaged public AI use for protected health information and vendor contract reviews with an AI lens. For tools that touch protected health information, care decisions, or claims, tighter review is non-negotiable, and if no one owns a tool, no one is watching it. The gap between AI adoption and governance is real. It is already causing breaches, and it is not primarily a technology problem. It is an operating model problem. Buying AI is the easy part. Running it safely inside a health system is the hard part. And right now, most health systems are still figuring out the hard part. I'm the healthcare architect. See you in the next.